good evening, everyone. Welcome to My IVF Answers. Welcome to our webinar. We are back with our topic tonight. We are back with Dr. Natalia Szlarb. You can see her right here. Hello, Dr. Szlarb. It's great to have you back. It's been a while again, but I'm glad you have been able to join us tonight. How are you feeling? It's great to have you for sure.
Thank you so much. Thank you for the invitation. For me, it's a very special webinar because we are celebrating 40 years of UR in Spain with 15 clinics around. But even though, it sounds very serious, 40 years of UR, we are going to talk today about something completely new, which is the use of PRP in reproductive medicine. So I'll try to explain to you why do we use it, and I'll try to make it as interesting for you as possible.
We have no doubt here. The topic is definitely interesting. And remember, we will start with Dr. Szlarb's presentation, and afterwards there will be time for your questions. You can put those in the chat. You can do it now, later during the presentation, or after the presentation during our Q&A session. Don't hesitate. This is your time. We are here to help you out with some of your doubts as well. And remember, it's being recorded. And I also want to say that, as you know, we are trying to gather here at least every single week to support you, to give you some answers, and give you the opportunity to ask your questions to the fertility experts, best fertility experts in the field, as Dr. Natalia Szlarb here. And as she mentioned, she's the gynecologist and fertility specialist at UR Vistahermosa. And I'll be happy to, I'm looking forward to the presentation that you have prepared. So I think we can go ahead with this. The presentation is right here. Yeah, are you ready to start?
Yeah, let's go for it.
Brilliant. Thanks so much. Let's go ahead.
Thank you. So we have to be aware that PRP has been used for quite a while in medicine because you can imagine that the whole blood is rich in red blood cells, white blood cells, and platelets. So when you centrifuge them, when you put them to the special machine and it gets a certain velocity, then the cells are staying at the bottom of the tube, and the serum is usually in the upper area. And when you add special factors to this kind of blood, then the platelets which are inside are releasing all the good nutritive factors, which are mentioned here as cell growth factors like cytokines, factors of angiogenesis, vascular growth factor, the factors that are allowing other cells to migrate to the area when PRP is injected, and it improves the tissue regeneration. So you can imagine that the first use of PRP was in the regenerative medicine. I remember to my German times, my colleagues in orthopedics were using a lot of PRP after knee injuries. Germany is a cold country, so everybody is skiing in the winter. So people after these injuries injure knees. This is the most common injury. It was the moment where PRP started its work in about 15-20 years ago. And then when we talk about the history of PRP, the aesthetical medicine, until now, the women in advanced age, they know that there's nothing better than the mesotherapy with PRP, where I've seen myself papers published, evidence-based medicine papers, where the pieces, the biopsies of skin were taken before PRP injections and after PRP injections, And what we were able to see that the collagen that is at the bottom of our skin in the connective tissue with the age is getting completely disorganized. And when you inject PRP, then the collagen starts from the wavy structure, have a very organized structure, and that improves the skin quality a lot. So after this positive experience in regeneration and in aesthetical medicine, gynecology decided to use PRP in actually 3 indications: in premature ovarian failure, in low ovarian reserve patients, and in endometrial regeneration. And today we are going to talk about each problem separately. So platelet-rich plasma is used in reproductive medicine because the platelets, after the special centrifuge preparation that I mentioned, release all the good stuff, all the nutrients that can have a positive impact on the uterus lining when we face the bad growth of lining, recurrent implantation failure, or people have premature ovarian failure, or they suffer the poor ovarian reserve due to their age. So the platelets usually release platelet growth factor, insulin growth factor, tissue growth factors, and vascular factors, which are responsible for better endometrial response or for better ovarian response. So you can imagine that in patients with ovarian failure, after injection of PRP, we see that the number of antral follicles is growing. Antral follicles are the small potential eggs that we measure at the beginning of each cycle, which have between 3 and 6 millimeters. It depends on the school where you're from, how you measure them. The cortex volume is improving and the angiogenesis is improving. So if the angiogenesis is improving, then we can imagine that the hormones that the patients are injecting in the following cycle after PRP are penetrating, are getting to the ovary better, and then the response of the ovary to the stimulation will be better. On the other hand, in people with Asherman syndrome or people with after curettage, after DNCs, where the endometrial response is not the best. If we treat these patients with PRP, of course, we cannot say that. This is the very common question: if the PRP can be a treatment for Asherman syndrome. The answer is no. The PRP cannot be the treatment for Asherman, but not each Asherman syndrome is equally severe in one patient as in the other patient. There are some patients that have like parts of the endometrium and uterine cavity damaged with adhesions, and some parts are still viable and some parts are still working. So in the parts of the Asherman syndrome, in the not severe cases of Asherman syndrome where the endometrium is still, there are some islands of endometrium working, we can use the PRP, and then we see that the number of pro-inflammatory factors is going down, that endometrial thickness is improving in these areas when it's still viable. And then if you perform the transfer to the transvaginal scan, and when you see exactly where you place the embryos, you have a chance to put them in the Asherman area which still endometrium is there, so you have a chance to achieve pregnancy. Of course, we are not using PRP on daily basis here. It's not as simple as, you know, endometrium growth with estrogen. There are selected cases, severe cases where PRP is used. So 3 indications that I mentioned for Asherman syndrome is ovarian regeneration in patients with premature ovarian failure or patients with advanced maternal age and low ovarian reserve. So this is the ovarian indication, and the other indication is endometrial indication, patients with Asherman syndrome, poor response, recurrent implantation failure. So low ovarian reserve, you have to imagine when you come to UR Vistahermosa, we always, before we perform the IVF cycle, we always establish something called your ovarian reserve. There are 3 A's in your ovarian reserve. There's your age, your AMH, and your antral follicle count. And then, you know, the story is very, very straightforward. It means when your AMH is more than 2 nanograms per milliliter, you have a good ovarian reserve. When your AMH is between 1 and 2, you have diminished ovarian reserve. When your AMH is under 1 nanogram per milliliter, you have low ovarian reserve. So in patient with low ovarian reserve, I just have a patient like today with AMH 0.3, 0.4. This patient, what we do is we want, through ovarian rejuvenation, increase a number of antral follicles, because for them, 1 egg or 1 antral follicle more, it's a blessing, especially when you travel to Spain from the other part of the world. The patient is from Ethiopia, okay? So she doesn't have an access to good fertility centers in her country. So she's 36, okay? So she still has genetically good quality of eggs. More than 50% of eggs in her age are genetically normal, but her AMH is low. She has low ovarian reserve, and for this kind of patients, we cannot improve eggs quality, because eggs quality is your age dependent, but we can slightly increase the number of eggs through the increasing of antral follicle count number before we perform an IVF cycle. So there are 2 separate entities, low ovarian reserve and premature ovarian failure. Premature ovarian failure, we have to understand that menopause is the moment where that happens between 45 and 55 years old, where women naturally do not produce eggs anymore, and 1 year without period defines them as a menopause. There are women who experience this no production of their eggs in their ovaries before 45 years old, and this is called premature ovarian failure, that too early they are not producing eggs. And for this kind of patients that develop this kind of problems, we also offer the PRP treatment. We cannot expect miracles from PRP. Sometimes people, especially after chemotherapies, strong chemotherapies because of breast cancer, leukemias, after complicated oncological stories, they ask if they are eligible for PRP if their AMH is 0.2 or 0.0. No. The answer is no. You're either, before chemotherapy, you freeze your eggs that we can use after your oncological disease is under control. But PRP, it's not the best solution for somebody, after chemotherapies. So premature ovarian failure, if we see naturally that your AMH is dropping, this is the moment where we can use PRP. I like this chart because it shows women in Spain how they plan pregnancies. You see that in the north of Spain, the maternal age is 32, 31 years old, and then the more to the south, the younger mothers we have. So in big cities in the north of Spain, these are the places people are more educated, women are more independent, and they grow their careers, they postpone their maternity, and this is the moment where you either freeze your eggs when you are 35 or younger, or when you are in advanced maternal age with low ovarian reserve, you have to apply for PRP, and if this works, amazing. If this doesn't work, then the only way to help you that we have, it's an egg donation. So don't wait too long to be a patient, to be a candidate for a PRP. Try to do something before you are 35. So then you can see the reproductive medicine books just as a theory. Endometrial line improvement. So yeah, I have seen patients after a couple of DNCs. You know that there are modern countries in Europe, but with a very stiff legislation when we talk about reproductive medicine, like Germany, where genetical testing of embryos is not allowed. Women experience recurrent implantation failure, and then what you do after this? You do DNC, dilation and curettage. You remove the tissue of the embryo that probably has a bad genetical quality. And the more often you remove, the more DNCs you have, the more often the problem with the thickness of the lining to grow in the cycle where you need to transfer the embryos. And then because PRP has this rich nutritive factors from platelets, we see that there's an improvement in the uterus lining thickness. I have seen some cases where it took months to grow the good lining, and then improvement with PRP. What was interesting for me, that after the delivery of a first child, trying for the second one, when the body has been trained, the growing the uterus lining the second time has not been that difficult as for the first time. So these are like two main indications. And then the implantation failure. There are papers published where we see that there's nothing more we can do. We transfer the best quality embryos of egg donor or embryos of genetic patients of patients' own eggs, and it's still not working. We add a lot of immunological protocols to make your NK cells come down. And if we tried everything and it's not working, then also we can try to flush your lining with PRP to improve the implantation. So customizing, so making this PRP story more personal. We have to be aware that it's a clinic where doctors that work here, majority of us have more than 10-15 years experience in reproductive medicine. The founders are about to retire, So we perform here school medicine. It means the patients, when they're coming to us, they're always correctly questioned, that we always see the medical history. We always examine patients. We always perform uterus scan, ovarian scan, and we see what protocols have been used in your previous treatments in other clinics, and we are looking for a solution. We see what can we improve while you'll be treated with us. We perform also blood results, not the simple ones, but also the hormonal results, AMH, prolactin, TSH, and then we give you our honest opinion. We have to be aware that even though we give you some honest opinion, I have one of my best friends now in the treatment, and she is 38, and her AMH is 0.2. We do cycle monitorings. We do FSH in every cycle the last couple of months, and I see her FSH 20, 30. So I know that the inclusion criteria for the cycle are not there. So you have to imagine that if in the ovaries there is no eggs, they give indirect message to our head, to hypophysis, and then hypophysis is producing high levels of FSH. So I know that in this cycle, no matter what I'm gonna do, I will not have eggs. And this patient is not ready for egg donation, even though in the last cycle we had FSH 34, which is perimenopausal, not saying menopausal, and she asked me if she can do ovarian rejuvenation, hoping that she's under 40, that her eggs are still 20-30% are genetically normal, and through PRP maybe we will increase the number of antral follicles, and maybe we will lower her FSH to improve her outcome in the IVF cycle. So as I say, the PRP is not something that we use routinely in reproductive medicine. There are selected super complicated cases in which it's very difficult to apply school medicine, and this very modern, innovative approach, which is ovarian rejuvenation, can be used. So in UR, we always adjust a dose of FSH, LH hormonal stimulation to your AMH. Means the lower AMH, the lower dose of medication you are giving to your patients, because otherwise you're going to block these ovaries. I was raised in Detroit, Michigan area in the Ford industry area. You can imagine that yesterday I was driving my car and I was giving it gas, but the engine was broken. So I was giving gas and the car was not, going in any direction. The same is with ovarian tissue. If there is no antral follicles, if there is no horsepower there, no matter how much gas you're gonna give, no matter how much hormones you're gonna give to the patient, the ovary will not do anything. Yeah. So the lower AMH, the lower dose of hormones you have to give to your patients. So this is very important. In endometrial regeneration, we use Viagra vaginally, and I'm always famous for saying Viagra vaginally is good for you. So it's not a commercial of Viagra, okay? So these vasodilators, you please don't take them orally, because you're gonna, fall down without the blood pressure. So you just take them vaginally in the morning and in the evening, and if you combine, with high dose of estrogens and with flashing with PRP, we have a chance to improve the uterus lining thickness. But as I say, quite often it takes months to work on the uterus lining thickness. Now, how the preparation process goes. So you have to have a centrifuge where for endometrial rejuvenation, we need 2 syringes of blood of 10 milliliters, and then it's prepared that out of this tube, syringes of 10 milliliters, we have plasma enriched in this all good stuff that we mentioned. The platelets are activated with calcium chloride, and this calcium chloride makes platelets to release the cytokines, the growth factors. And we use it fresh, so it's flushed to the endometrium immediately after preparation. In the ovaries, we need more blood because we need 4 10 milliliter syringes, and then 3 milliliters of PRP is put to each ovary. And it's also everything that is performed in UR is we have a luxury of having a lab upstairs, so it's fresh plasma injected to your ovaries or your endometrium flushing. So this is how you can imagine, the whole blood. This is how it looks like. And after that, putting this to the machine, the red blood cells, the platelets, the leukocytes, yellow cells are in the lower at the bottom of the tube, and all the best nutritive stuff is in the upper part, and only the upper part is taken to your therapy. The problems is organizing it, especially when people are coming from the other part of Europe. So usually when the cases are complicated, we give it on day 8, 9 of a cycle when people are taking oral estrogens, and 48 hours before the transfer. So patients usually are 2-3 days before the transfer here, or in selected cases, they're almost for the whole cycle here for at least 14 days. In ovarian rejuvenation, the problem is even more complicated, because in ovarian rejuvenation, it has to be injected 1 month before we treat you. So people have to fly for one time for ovarian rejuvenation, and then 1 month later for the treatment, when they're putting injections to let their eggs grow. So, but no worries. What we usually do is, on the day of a first appointment, I'm always very famous for, organizing the workflow that patients are getting their consent, medication protocol, and prescriptions sent on the same day as the first appointment happens. So on the medication plan, we give you a proposal. How could we work? And patients later on, they can adjust it to their needs, to their work schedule. So everything is set up and adjusted to your needs. So this is how the dream lining looks like. It's 3-laminar. In American medicine, we say it's a sandwich lining. So you see here like an upper layer, middle, and the lower layer. So it looks amazing. I wish everybody after PRP, had this kind of lining. Advantages. What are the upsides of PRP? For complicated cases, this therapy is designed for complicated cases. It's autologous. It means from you. It doesn't present any rejections. it's not like sometimes you inject something, sometimes you inject medication to a patient and then you have an allergic shock or whatever. No, because plasma, people are afraid, oh my God, it's a protein. Yeah, it's a, can I have, a shock after this kind of injection? The answer is no, because it's your own protein. When patients are not ready for egg donation, it's one step before an egg donation, where we try to increase the number of antral follicles. So this is the moment where you try ovarian rejuvenation. Increases pregnancy by natural means, the uterus lining flushing, of course, with this good stuff, increases the thickness of the lining and the pregnancy rates. Asherman, complicated stories. When the whole uterus lining is with Asherman with adhesions, we have a problem. There's nothing we can do. Okay, then you need treatment somewhere else outside of Spain. But if there's Asherman or still in hysteroscopy we see some areas of the lining, then we can try to help you with PRP. The summary. We believe that PRP opens new possibilities in assisted reproduction. Is still the path to explore. I think that we need more studies to see how the tissues in the ovary or in the lining react after PRP, as dermatologists did with skin biopsies. Still it's experimental, so as I say, we do not use it routinely. We do it in selected cases. The results may be uncertain. I have seen a lot of benefits in uterus lining growth. Still in ovarian regeneration, we need better protocols to see better results, in my opinion. Okay, I think it's about it for today. So if you have any questions, I'll be more than happy to answer.
Brilliant. Thank you so much indeed for your presentation. As always, it's been thorough, it's been very helpful, and you've explained it beautifully. So thanks a lot for that. And well, it's time for the questions. And I'm not sure if you see it, but there are lots of questions already right here. So let's get going with those. We will try to answer them all. Okay. So here's the first question from AD. How long after ovarian PRP will you notice a change in ovarian function for patients with low ovarian reserve?
If you use a protocol that we implemented in our patients, it's usually a month or two after PRP that we perform an IVF cycle. It's either IVF low dose stimulation, or it's an IVF, it's a natural cycle, super low dose. Okay, so we don't want you to wait 2-3 months after PRP. No, it's usually done 1 month, and we know if it's working or not.
Excellent. Thanks a lot for the first question. And yeah, my next question: when do you suggest starting with the IVF cycle after PRP?
1-2 months after PRP. I wouldn't wait longer. And there is a moment in your life where you have to take decisions. So people that undergo PRP treatment, they usually have a couple of treatments in their countries unsuccessful. So if we see that PRP is working, great. If not, we have to switch the strategy for an donation.
Okay. Thank you again. Next question from AD here. Let me just, here's the question. So after PRP, can one go for ovarian fertility induction, Clomid, or Femara?
Sure, go for it. Yeah, sure. I'm not, like a big fan of Clomid, because Clomid, it works 1-2 cycles and then it makes your ovaries empty. But if your AMH is very low, some people say, I will not go to the operating theater for the collection of one egg. So, I want a stimulation with the Clomid. I want to do my cycle monitoring, and then, timed intercourse. This is something that you can try. Sure.
Okay. Okay, great. Thank you so much. More questions, different ones. Let's have a look at this one. So I've heard about that PRP is also used for adenomyosis. How is it done? How often should it be done?
We do not, use PRP for adenomyosis. Adenomyosis is the presence of endometrial tissue in the uterus wall. Okay, so what we usually do is a classical standard downregulation for 2-3 months to shrink the uterus, and then to get rid of the bulky uterus and get rid of this inflammatory, like sponge endometrial full uterine wall. As I say, I have no experience in adenomyosis and PRP.
All right. Let's have a look at not the next question, but it's regarding endometriosis this time. So I have low ovarian reserve from under 35, likely due to endometriosis. Is PRP used in those with endometriosis too? I also have issues with lining, never above 6.8 millimeters, though it's trilaminar, and have had 4 failed embryo transfers with good quality day 5 blastocysts. So looks like I should look at PRP to help with this too.
Okay, if you are 35, so you still have, you are young, you're still defined as young reproductive medicine. So you have to be aware that even though you are young, 50% of your embryos are good and 50% of your embryos are bad. So I'll be looking for performing 1-2 cycles with you to do something called embryo banking, to have at least 5-6 embryos. And we have to be aware that out of 6 embryos at the age of 35, 3 of them only will be genetically normal. If it's more, I work 20 years in gynecology, so I've seen in my life cycles somebody 35, 6 embryos, 6 genetically normal. I've seen this kind of miracles, but I can tell you what are their names and where they live. Okay, so it's like 2-3 times in 20 years career. Usually, statistically, 35 years old, 50% embryos good. And then if I have them frozen, okay, so this will be my step 1 of the treatment: get as many embryos genetically normal as possible. And step 2, transfer them to the lining that we are going to, work on, as long as we're gonna like it. So it's a lot, easier to transfer genetically normal embryos frozen, and then sometimes you grow lining not as usually at 21 days. Sometimes you grow them 40 days, and sometimes you grow a lining 40 days, and I cancel you because I don't like it, and then start again. So this will be my approach to you. And of course, if I talk about uterus lining preparation, it can be flushed a couple of times with PRP.
Excellent. Thank you so much indeed. I believe that was helpful and useful. So thanks a lot, Maya. And there's a follow-up from AD. So you said Clomid can make your ovaries empty. Is it better to use Femara then?
No, it's better to use FSH, LH. It's better to do an IVF cycle with low stimulation. Okay. I'm coming from doctor's family. The women in my family were almost all gynecologists. So I've seen, a lot of Clomid Femara cycles in Berlin of the 80s, before the, wall came down, before it got reunited. The problem is, there are some countries where, the access to reproductive medicine is not as in Spain. And the laws are, complicated. So doctors have you long time with Clomid or Femara. Do 1-2 cycles Clomid Femara. If it's not working, you're a candidate for an IVF cycle, and we have to take it from there.
Thank you again. Brilliant. And there's a thank you from our previous patient, Maya. I
Welcome.
believe it was helpful. Then, of course, thanks a lot. Okay, how about this question? So, do you recommend calcium activation in endometrial PRP?
You know, the secrets how the PRP is prepared. It's like cooking. So this is done by our lab, and we are not, we are not are going to discuss it with our lab director. So as far as I know, the platelets are activated with calcium.
Okay, sure. Thank you again. And Vanessa has another question. Sorry, just here. What about after one round of egg freezing if you are before the age of 38 and you want to maximize the amount of eggs retrieved in order to freeze?
You know what? It depends what AMH do you have. If you have AMH, 152 nanograms, you don't need PRP. But if your AMH is one-ish, 0.8, or one-ish, as I say, try PRP.
Mm-hmm. Okay, straightforward answer, of course. Let's have a look. Miriam has another. How often should PRP be performed after implantation failure and several early miscarriages before A, cryotransfer, and B, new IVF with PGTA?
So implantation failure, it's a very complex problem. So in order to solve this puzzle, you have to be a little bit like obsessive compulsive, means you have to check all the pieces of the puzzle: genetically normal embryos, implantation window, verified by the good uterus lining biopsy, where we see receptivity, where we see infections, where we see a lot of stuff, okay, where we can even see the immunology. And number 3 problem is NK cells, KIR, HLA matching of people. So don't think that the way I'm telling you this is that I don't want you to think that with uterus lining flashing with PRP, we can solve, the recurrent implantation failure. No, you have to work. Medicine is a game of exclusion. It's a puzzle, which is a game of exclusion. You have to exclude 1, 2, 3, genetic quality, lining biopsy, immunology, and then you can, look for help in alternative medicine, which is PRP, uterus lining flashing. And we usually perform in this kind of cases at least 2 flashings. Day 10 of a cycle, 9, 10 of a cycle, where we check the uterus lining thickness, and then 48 hours when people are on progesterone, 48 hours before we transfer. So it's done twice in the transfer cycle.
And again, thank you a lot for the explanation. And Sergio has another question. What do you know, if you know, combining the use of PRP with hyaluronic acid?
The question is where? In the uterus lining regeneration or in the ovarian regeneration? I've never heard about hyaluronic acid in reproductive medicine. You can imagine that I did master in aesthetical medicine in my life. So I've seen a lot of, facial cases and hyaluronic acid. And I know that it improves the collagen in the skin. I'm not sure if there's anything published about ovaries and the lining.
Crystal clear. Thank you so much indeed for that. Okay, let's have a look. We have a question here, sorry, from Michelle. So I also have fibroids and was told they didn't interfere with implantation. Unfortunately, it never worked for me. I am now 45, almost menopausal. I'm sorry, I'm sure there should be some sort of follow-up, I think.
I think that Michelle is looking for solutions. Michelle, we have to see your AMH. It's always ovarian reserve. Yeah, it's 3 A's. Is embryo donation okay with PRP? Perfect. I'm so proud of you that you are looking for an embryo donation or egg donation. you can imagine that in 2015, one of the biggest statistics was published about the embryo's quality due to our age. And my statistics regarding egg donors was a part of this project. So after 45, we have no genetically normal embryos. Okay, no, zero. Okay, so you need an egg donation. If you need a sperm donor, okay, go for it. Don't think that that PRP is going to be a cure for everything. It's going to fix everything. Try a good quality, A quality embryo or A quality euploid embryo. We have this kind of embryos frozen in our bank here in UR. So if you need them, we do have embryos from double donation, genetically examined, to be sure that they are healthy. Try this. If the lining has issues to grow, try PRP. If the lining is good, if the lining thickness is good means between 7-12 millimeters, you don't need PRP. But sometimes the problem could be your immunology, where your egg and sperm donor have to be immunologically matched to you. So, try one spontaneous good cycle with good quality embryo. If it's working, great. If not, dig deeper into your immunology. That could be an answer why this is not working.
Again, thank you, Michelle. I hope that helped. And actually, you've mentioned this already, actually, in this question, but here, 43H, 18 FSH, AMH 0.7, would this be PRP option, or should I go for donor?
You know what? The oldest patients that I've ever had with genetically normal embryo, it was a Chinese lady in London. We used to rent an office in London, Harley Street, before Brexit, which, I loved. I enjoyed working in downtown of London. And the lady was 45, yeah, and she had one genetically normal embryo in my whole career. And she got pregnant until 8 weeks of pregnancy. And then she miscarried because probably embryo was metabolically weak, not strong enough to develop to a baby. And then our papers published about mitochondrial quality of your embryos, okay, of mitochondrial age and this kind of stories. So you know what, if you are 43 and you have probably some IVF story behind you, go for an egg donation. And I'll be more than happy to help you.
Of course, thanks a lot again. Let's have a look. Of course, there are thank yous from our previous patient, Miriam and Michelle. So thanks a lot for your help. With that, a few more questions. Let's have a look at this one. So will PRP work for me? I have 0.01 AMH, FSH of 80. Visualizing my ovaries is usually hard. Will PRP give me a chance to conceive?
You know what? No matter how old you are, FSH, more than 20, it's super difficult, to make it happen. I had a couple of cases in my life because ovarian reserve is not only your AMH, it's the combination of three: age, AMH, and follicle count. So if I have somebody with that low AMH and this lady is 20 years old because she's in premature ovarian failure, she has the chance to have 3 cells and one of them healthy. If I have somebody with this low AMH and at the age of 40, there's no matter what I'm going to do, there will be no good eggs and there will be low number of eggs. Okay, so with FSH 18, I have never seen anybody generating me any eggs. I'm sorry. You need an egg donation, madam.
Thank you, of course, for again explaining. And let's have a look. Okay. Next question is up. And vaginal Viagra is not available in UK. Do you use a special preparation, or can the oral tablets be inserted vaginally?
You know what? The same Viagra as men take for fun orally, we can use vaginally. It's not like a difference between oral and vaginal Viagra. There are no like special specially composed vaginal pessars of Viagra. No, it's the same one. To give you a hand, Viagra, it's quite expensive, but there are other, brands, generical brands, which can be useful.
All right. Thank you again for this. Let's have a look at this question. So I have been told I don't ovulate anymore due to low estrogen and progesterone, but I still have periods. Is this something I should consider?
You know what? You have to get yourself the first appointment here with us, because when I see a patient, ovarian reserve is age, AMH, antenna follicle count. Okay, I'm like a broken record. It's always the same. And your low estrogens probably are a reflection of low ovarian reserve. And when you have low ovarian reserve, you have to take decisions. They work with your eggs, and if you have low AMH, but you are young defined under 35, 38, we can try to look, for treatment with your own eggs. But if we have a low ovarian reserve, low estrogens, and you are over 40, then you need an egg donor. So you need an appointment, and you need an assessment of somebody who will not look for like end products of reproductive medicine, which is estrogen and progesterone. Come on, madam, I can give you oral estrogens, and from estrogens 30 units, I can have 200 units in 3 days. Okay, the question is your egg or donor egg, your AMH or AMH of your donor. Okay, so take it one step at a time. Get yourself an appointment, and we'll be more than happy to help you.
Brilliant. Thank you so much indeed. Okay, you've mentioned this before, but if you can help tomorrow, so how long does the effect of PRP last?
2 months, 3, not more.
Okay.
So
sure.
the answer is, if you do PRP, get yourself 1-2 months before you perform a somebody suggested Clomid cycle or the treatment with IVF or natural cycle. The difference IVF natural cycle is, of course, the dose of medication injected.
All right. Again, thank you so much for this. Okay, sorry. There is a question here. I mean, with the statement, yeah. So my wife is 25, no menstruation, without contraception, no conception last 9 years. And also all laboratory HHG result is normal. All doctor recommends is exercise only. Anything you can add?
The exercise for what? For fun? Go for it. But if it's for fun, good. But if I want to see fruits of my work, I want to see why. What do we work for? So yeah, you are adding here some more information. FSH, LH, AMH, normal. You have to give me like certain numbers. So I need to know FSH day 3, what? How much? 10, 27, I don't know. AMH, the same. And I hate the results. With all the respect, I hate this European results saying good for your age. There's nothing something like good for your age. There's no AMH good for your age. There's AMH more than 2, good ovarian reserve, AMH between 1 and 2, diminished ovarian reserve, and AMH under 1, which is low ovarian reserve. And no matter in which age you are, the AMA low, middle, or high can happen to you. So, sir, I will be happy to discuss the results with your wife and you in person on the first free appointment. I'm every afternoon in UR. So show me the numbers and I'll tell you which direction we go.
Thank you so much indeed. And I just want to mention, because someone asked about any contact details, and I believe it was in the presentation, right? Because I don't remember exactly. What was the email address that anyone can use to get in touch with UR Clinic and get some more details as well?
There's,
Can
I
remind
think, international at Vistahermosa.com, and then the leads can also come to you to IVF Answers, and then can be sent to us.
Of course, we'd be happy to share that as well. So feel free to get in touch even with me. I'm be happy to forward any of the questions you would, if you wish to get some more details. Remember, it's always best to get a consultation and get some more details, as Dr. Szlarb would need definitely more medication records, etc. I mean, medicine records, etc.
Yeah, sure,
right?
sure.
As always, medical history. That's what I meant to say. And let's have a look. A few more questions are left. So just give me a second. Let me go back. I'm 40 and collected 5 eggs on last cycle. As you said, that equality is linked to age. Would PRP be appropriate?
I was waiting for this question. PRP will be appropriate to increase a number of eggs, but it will not increase a number of genetically normal embryos. What you can do is you can do something called embryo banking, or you can do something called egg banking. Madam, freeze yourself, every 2-3 months, 5 eggs. At the end, after, a year of work, thaw them all, fertilize them all, develop them to day 5 embryos, develop them to the blastocyst, day 5, 6, biopsy them, and then you'll be surprised. Only 20-30% of your embryos will be genetically normal. The blastocyst quality is due to your age, and there's nothing, we can do about it. What you can increase through PRP, as we said, is the number of antral follicle and the number of potential eggs. So you know what? If through PRP before each cycle you increase a number of egg of 1 or 2, so imagine instead of having 5 eggs in one cycle, you will have 6 or 7. After egg freezing, 3 cycles, you would have had 15 eggs if we count 5 eggs per cycle. But if we count 7 eggs per cycle, 7 times 3, 21. So this makes sense. Okay, this will increase just a number of eggs, but this doesn't have to do. The PRP does not have any impact on the genetical quality of your embryos. It's what it is. Sorry, guys.
Thank you, indeed. And Eduardo would like to know, do you have any experience with PRP extraction kits?
You know what? I have a luxury that I sit in one of the biggest hospitals in Alicante. So my PRP extraction kit is a 10 milliliter syringe that I have to take 2 or 4 of them and send it upstairs to the lab, and then they will do their magic. Okay, so no experience, and the beauty that everything's done fresh. So basically, people come 10 o'clock in the morning, and 1-2 hours later we can do PRP of lining or of ovary.
Okay, excellent. Thank you. And we already also discussed this, but if you can have a look, so you indicate intra-ovarian PRP in cases with the diagnostic of endometriosis.
As I say, I have no experience with endometriosis and PRP. I'm not a big fan of injecting anything to endometrial cyst. As a matter of fact, I had a couple of cases where I did a puncture of endometrial cyst, big cysts, which were infected, and people had serious complications. Okay, so if there is endometriosis, get rid of this, operate it. Don't go on, down regulation 3 months. Be on birth control pills, long cycles, without stop, without periods. So endometriosis you do not bleed outside and you do not bleed inside. So endometriosis doesn't grow in your tube, in your ovary. You have no cycles. There's no menstruation. Okay. And then if you get it under control, then perform an IVF cycle. And as I say, my experiences with puncture of endometriosis is very negative.
Okay, so clear again. Thank you, indeed. We are almost coming to an end. There are like 3 questions left, so if you have more, those will be like the final call for the questions. Go ahead, type those in. And the question is straightforward. So is PRP ideal for recurrent pregnancy loss, right? RPL.
There is no ideal solution for recurrent pregnancy loss. You have to see genetical quality embryos, endometrium quality verified by a serious biopsy. You can send no names. You can send this biopsy to Valencia or to Barcelona to process, and immunological workup, HLA matching of patient donors or patient between themselves. This is the ideal approach for recurrent pregnancy loss. If obsessively, compulsively, you solved all the pieces of puzzle and everything is under control, then you can try to flush the lining with PRP.
All right. Again, thank you indeed. And as you know, thank yous are coming up your way, and there's quite a few from our previous patient as well.
Guys, thank you so much.
It's always great to have you and be able to explain and give you some ideas perhaps or some tips. So one more. Can one use DHEA to improve ovarian reserve before IVF cycle?
You know what? I know this American approach, DHEA, CoQ10. I'm a product of these approaches. It can improve. There are papers published that this can improve a little bit of your ovarian reserve. I haven't seen any papers published regarding the numbers. Okay, so DHEA 50-75, 2-3 months before you do a cycle, go for it. Okay, do 1-2 cycles with your own eggs, and this, vitamins, DHEA. There are some papers even published about growth hormone. So try. If it works, amazing. If not, call us first appointment, and then we have to switch gears and decide what can we do for you.
Okay, thank you so much indeed. And we already kind of answered, but let's have a look. Okay, maybe you can add something. So I only produce 3 eggs each cycle, so would PRP be an option? I have premature ovarian failure. I'm 42. I've had failed cycles with maximum dosage, 3 failed cycles before.
You know what? Get yourself a cycle with PGDA. See if genetically normal embryos are produced. I just had not long ago a girl. She was 41. She had 20 eggs, 10 embryos, everything genetically abnormal. She was crying in front of me. I had to be, I had to be a medical professional in front of her. So I couldn't cry in front of her, but I cried at home. So if you know that there is no genetically normal embryos, there's nothing you can do. As I say, I had one of my, most challenging cycles I've ever had were 3 eggs, 2 embryos, 1 genetically normal of somebody who was 27. So her euploidy rate is 80%, number of genetically normal embryos. At the age of 42, the euploidy rate is less than 10%. So out of 3 eggs, with a lot of fantasy, maybe 1 will be good one. Get yourself this piece of evidence. If you're lucky, you'll be pregnant. If not, you need an egg donation. And don't waste time, money, emotions in wars, in projects that we are not going to win.
And again, thank you so much. And that was our actually final question. So thank you indeed.
Thank you.
And as you can see, again, thank yous are coming up. Dr. Szlarb, great to have you back for sure. You have explained it very well, and I'm sure everyone found it very useful. And I hope that even if a little, we were able to help you. And of course, before we finish, anything else you would like to add, as always?
You know what? I'm so happy that the COVID and the war and whatever more crazy is going to happen is not going to change our approach to reproductive medicine. We just have to be there strongly for our patients, for our colleagues. And if you have any doubts, if you need a second opinion, we do run first appointments online for free. Feel free to contact us. I have, PAs which start a day with me in Russian, German, English, Polish. So everything we try to adjust. The only probably language that I do not run fluently is French now. We have somebody else who's running the show. So
There's always someone, right?
there's always someone, because we love our patients, we love our job. It makes us forget how crazy this world and people got. So don't hesitate with any personal doubts. Contact us, and we are there for you always. Thank you so much.
Thank you so much indeed. I just put the email address just in case if anyone would like to get in touch with Vistahermosa and her team and Dr. Szlarb's team, of course, you can do so. And that way, I'm sure they will be happy to help you with some more details. And as we know, all the doctors need all details as well to help you out. Thank you indeed. We will be back actually this week. We have 2 webinars, and next week we will talk about, this Thursday, actually, we will talk about nuclear transfer techniques. So if this is something that sounds interesting for you, join us. We will talk about it on Thursday at 7 p.m. UK time. I can only encourage you to sign up and join us on Thursday. And that is it for today. Excellent webinar for sure. Lots of useful details and interesting topic. And of course, our amazing expert, Dr. Szlarb, was here. So thank you a lot again, Dr. Szlarb. Looking forward to some more events as always. Thank you, everyone. Enjoy your evening, and I hope to see you here quite soon as well. Thank you, and take care.
Welcome. You too. Have a great evening. Take
Bye.
care. Bye. Bye.
Bye.